The next late-breaking session is Availability and Benefits of Lifestyle Management Programs for Arthritis to Reach Minority and Rural Populations. This session has been pre-recorded and the speakers are in the chat. Feel free to interact with them during the presentation. After the session, the speakers will join live to answer your questions. Thank you for participating in Sophe 2021 DX.
Hello, everyone, and welcome to the Sophe 2021 Digital Experience Annual Conference. We're so excited to have you here. My name is Jordan Furmeister, and I'm the moderator of the session today. Today's session is titled G4, Availability and Benefits of Lifestyle Management Programs for Arthritis to Reach Minority and Rural Populations. At the end of this session, participants will be able to describe at least 3 characteristics of Arthritis-appropriate evidence-based intervention, or AAEBI, programs, otherwise known as lifestyle management programs for arthritis, recognized by federal health agencies, including the Centers for Disease Control and Prevention and the U.S. Department of Health and Human Services Administration for Community Living. The second objective is to describe the benefits of providing an AAEBI program and opportunities for federal funding. The third objective is to describe principal findings of research study on AAEBI programs and the need to reach minority and rural populations. At the end of presentations, we will be taking questions from our attendees. For our digital conference attendees, you can enter your questions in the chat box at any time during the presentation. Those questions will be read aloud for the speakers to respond to, and we will answer as many questions as our time will allow. Now, I would like to introduce 3 speakers on our presentation today. The first speaker that you will hear from is Dr. Kate Lorig, a partner of the Self-Management Resource Center. Kate also served as the director of the Stanford Patient Education Research Center and was a professor of medicine in the Stanford School of Medicine. The second speaker is Leslie Steinman, a research scientist at the Health Promotion Research Center, or HPRC, part of the University of Washington School of Public Health. The third speaker that you'll hear from is Dr. Nicholas Barasek, the Director of Communications of the Osteoarthritis Action Alliance in Chapel Hill, North Carolina. We're excited to hear from each of you today, and I'll hand it over to Dr. Lorig to start us off.
I'm delighted to be back at Sophe. It's been a while. And for those of you that know me, you know that I'm a storyteller. So let us start with the first slide, and I'd like to tell you a story. So why arthritis? Many, many, many years ago, when telephones still had push buttons, I was offered a job at Stanford to put together an arthritis program. And because at the time I was a doctoral student, it was a pretty good deal because they'd let me do my dissertation and they were going to pay for it. And so I said, fine, I'll do this, but you need to understand that this is not what I'm interested in. And I really don't care about this topic at all. And thankfully, the gentleman that eventually became my mentor, Dr. Halstead Holman, said, that's all right, stay for 2 years and then you can do anything you want. And now we're many, many, many years later, and I'm still presenting on arthritis at Sophe. So he had wisdom that I didn't have. I should also tell you at the time that one of the luminaries in our field, who I will not name, said to me, Kate, what you're doing is really very interesting, but please don't plan to make a career of it. Nobody makes a career with arthritis. So don't always listen to good advice or bad advice. So why arthritis? Nearly 23% of adults in the United States have arthritis. There's kind of a toss-up between it and hypertension is the most common chronic illness, but you don't hear about it a lot because it doesn't kill people. Or at least it kills very, very few people. It does make 54 million people miserable. And if you want to have some idea of what it's like to have arthritis, when you're finished watching today, go to your kitchen, find a dried bean or pea and put it in your shoe and just wear it for the rest of the day. And that will give you a vague idea what 54 million people are doing every day. There are more than 100 different types of arthritis. I'm not going to talk about them all today. Nearly all types of arthritis have limitations and have limitations with daily activities. And one in four people with arthritis have severe joint pain, and almost all of them have persistent joint pain. So you're now talking about 54 million people that have limited mobility and have pain. Nearly a quarter of the people with arthritis report having no leisure physical activities. And yet, as a profession, we as health educators tend to pretty much ignore this field. And we do it for a couple of reasons. Number one, because prevention is very, very difficult. In fact, it's almost impossible. There's a few things you can do to help prevent it or delay it, but not much. And there's not terrific treatment, at least for the biggest form of arthritis, which is osteoarthritis. And so we tend to work at the things that are kind of seem to gloom larger: hypertension, diabetes. But I want to just remind everybody that if you're working with older people, you're always working with people with arthritis. And no matter what you're doing, if you don't consider that, probably what you're doing is not going to be successful. So that's all you're going to hear about arthritis for today. Let's go on a little bit and talk a little bit about exactly what is an evidence-based program. This is not something that we kind of thought up last night. It was a many-year effort between the federal government and the Evidence-Based Leadership Council to try to determine which programs were actually going to be funded by the federal government for older Americans. And so some criteria were set upon, and to be called an evidence-based program, you must meet these criteria. Not only must these criteria be met, but in addition to that, it has to be vetted by a committee of the Administration for Community Living. So all of these programs have been tested in trials using experimental or quasi-experimental design. They need to be fairly large trials. 50 to 100 people is kind of a minimum. They have to be fully translated to a community site other than the site where the experiment was originally done. There needs to be a peer-reviewed journal article somewhere. And probably most important of all, there needs to be all the products available so that other people can replicate the programs. These are training manuals, maybe training films, fidelity manuals, that maybe include such things as licensing. So there's all kinds of these dissemination products that are necessary. Next, please. What are these programs? Well, the CDC has a set number of programs which they will actually pay for as evidence-based programs. These include the Arthritis Foundation Aquatics Program, which, as you can see, is a swimming program, or in water art program, Activities for Daily Living, which is an exercise program, Enhanced Fitness, another exercise program, Fit and Strong, which is still yet another exercise program, specifically tends to be more for lower extremities. And finally, Walk with Ease, which is a walking program. And you're going to hear more about that a little bit later today. Now, in addition to these programs, next slide, please. There are some lifestyle programs. There is the Chronic Disease Self-Management Program available in English and Spanish and several other languages. and the chronic pain self-management program, available in English and Spanish and a few other languages as well. So these are the programs that the CDC will actually pay states to do. States can apply for grants each year and can be paid to do these programs. Next, please. How are these programs delivered and where? Today, these programs are delivered literally in every state in this country and in 30 or 40 countries abroad. They can be done in person, one-on-one, or in small groups, depending on the program. They can be done on the phone, again, in person, one-on-one, or in small groups, depending on the program. They can be done in Zoom or using any other virtual program. They can be done on the internet with asynchronous. That means people don't all have to be there at the same time. They can be done over time. They can be done by snail mail. And more, they're being done by a combination of these. Now, not all programs are being given by all modes, but these are the modes that are kind of available today for giving these programs. And one more, please. There's a slide here just to give you some information about how you could engage in these programs if you want to. It's really hard to remember things on slides. So if you remember nothing from this slide, remember, if you're at all interested, contact your local area agency on aging. All of you have one. There's one everywhere in the country. Contact them and they'll help you. I've had a delightful time being with you today. I wish that we were all in St. Louis together, but hopefully next year. So long for now.
Thanks, Kate, and thanks to Jordan and Nick for being here as well, and to Sophe for hosting this opportunity for us to share with you all. And yes, we look forward to being with you live in person again, hopefully in the future. So I'm going to be talking a little bit about our work to promote older adult health equity during COVID times and beyond, and specifically looking at evaluating the public health impact of remote evidence-based programs. So the programs that Kate just described all really had to pivot to doing their work remotely back about a year ago, spring 2020. And I'm going to be sharing some lessons learned from a national survey that Kate and I and others did as part of the Evidence-Based Leadership Collaborative, as well as talking about what's ahead for learning together from these programs. Okay. So first, what is the opportunity here with promoting health equity with remote evidence-based programs? So we know that older persons are disproportionately impacted by COVID. And that within older adults, that certain populations have really had worse health outcomes or worse access to care because of sheltering at home and other distancing guidelines. So these include older adults living with chronic conditions, including arthritis, older adults of color, older adults who speak languages other than English, older adults in rural areas, and older adults living with disabilities, among other underserved populations. So there's a potential here for these evidence-based programs that promote physical activity, chronic disease self-management, falls prevention, behavioral health, and how they might improve access to care for these populations as folks are having to do things remotely. We also know that with COVID and distancing guidelines that older adults have increased their feelings and actual isolation and loneliness. And so is there a potential by moving these one-on-one and group programs online or on phone or through mail or even through Zoom like we're using today to really improve social connectedness for folks who are quite disconnected at this time? Lastly, we know that there is a digital divide that was existing before COVID, that COVID has sort of brought to light even more in terms of people who do and don't have access to technology to access services. So is there a way we might use these evidence-based programs being done remotely to help close that divide and really improve equity and access to care? We know there are barriers to doing these programs in person, such as transportation, mobility, weather. And so we're also looking at, are there potentials where we can reach people doing this work remotely that we weren't able to reach before? So I'm going to be sharing in the next few minutes here lessons learned from a national survey of remote evidence-based programs. And I show this picture of this rose bush outside my house, that photo credit to my daughter, that really indicates the mood of this last year in learning together. So we recognize the thorniness of the challenges of working during a pandemic. We are all having to work harder and longer. And also the opportunities, the roses that have come from this time as we've had to really innovate and be creative together. And we've wanted to do remote delivered programs for a while, and the pandemic has sort of pushed us all to create these models together. So I'll be sharing what we've learned. Our guiding framework for this evaluation is a model called REAIM, developed by Dr. Russ Glasgow and colleagues. And this model is important here because it doesn't just look at what we traditionally think about with evaluations, which is effectiveness, does the program work? But it also looks at these other key factors that are important to actually delivering a program in the real world and getting it to the folks that need it. So it looks at things like who's being reached, who's represented by these programs, as well as who's not being reached that we need to do different outreach and engagement strategies for. Who's adopting these programs? So not just reach in older adult participants of these programs, but what providers and leaders and health educators and organizations are being trained to do this work, and who do we need to do a better job marketing to and building capacity to deliver these evidence-based programs. Implementation refers to how the programs are being implemented, what's working, what's not. Are they being done with fidelity to their core components, and at the same time adapting appropriately for local context? And then how are these programs being sustained over time? So we launched a remote evidence-based program survey, thanks to Kate and her leadership back in April, right after the pandemic hit, just to understand what is happening with this work. As Kate shared, these programs were traditionally done in person, and over time last year, many models shifted to doing their work remotely. So we wanted to know what programs are being done remotely, how many organizations are doing this work, how many people are being served, who is not being reached, who is being reached, and then looking at some of these facilitators and barriers to implementation. What is working well and what's working not so well, because that points to opportunities for how we can all do this work better. So these were the people who participated. This data is a little old, admittedly. This was the end of November. And so part of why we wanted to present to you today is really to learn kind of where are things now, because this is truly a moving target and we are learning every day. At the time in November, we had 650 respondents to the survey. We also collected follow-up data from 143. These represented over 400 organizations, representing a third social service organizations, about a third healthcare, 1 in 5 identified as a public health organization, which is very relevant for this audience. And we also had people coming and joining and sharing from educational settings, research, and state government. And we had nice representation across the country. 36 states were represented. We also did have some participation from people who are doing this work outside the United States. So I'm going to show you the next few slides, which programs were represented in the survey. Some of these programs are the programs Kate just taught you about in terms of these programs that have been approved by the CDC as lifestyle management programs for arthritis. But as Kate shared, if you're serving older adults, you're serving people living with arthritis. So we have other programs represented here that are not officially on the CDC approved list, but that are reaching people living with arthritis. So we have chronic disease self-management programs, behavioral and mental health programs, caregiving programs, and falls prevention, nutrition, and physical activity programs represented. I will say that at the time of this survey, some programs were still building their models for remote delivery. So we really are learning in real time, particularly from these fall prevention and physical activity programs that really need to establish safety considerations before moving to remote. So what did we learn about what remote modes were being used? So about half of the organizations surveyed are delivering their programs using video conference only. So these include Zoom, Teams, and other video conferencing platforms. And we saw that over time, we really increased that percentage. So when we started doing the survey in the spring, it was about 40% were using video conferencing only. And over time, as people improved access to technology for both older adults as well as for the leaders trained to deliver this program, we saw this percentage increase. In terms of who's being reached, from those surveyed, they were really excited that they had reached over 6,500 people with these programs. And this is amazing given all the stresses the pandemic put on us, as well as knowing that many services and supports were not available during the pandemic. About half of those participants also received mailed materials, whether toolkits or books to support their learning and skill building. And what was really exciting is we heard that some people who had never done an evidence-based program were participating. And some of this had to do with access in terms of transportation or mobility. Some of this had to do with the challenges of sometimes filling a workshop in a rural area. And some of this had to do with just preferences. You know, for some people, they're more comfortable doing this work online or remotely than they may be going into a room with people they don't yet know. Not surprisingly, the biggest group of people who are not being reached are people who do not have access to or comfort using technology. And this is not just video conferencing platforms, tablets, lack of reliable internet, computers. This is also people who might not be comfortable using the phone as well, particularly if we think about people maybe with some hearing limitations or just some mistrust in terms of who's calling them on the other line. And we also heard that people who identify as a group that is traditionally underserved may not be being served as well. And so, for example, people who speak languages other than English may not be receiving their program because it hasn't yet pivoted to be done in another language remotely. That said, we've also heard that for some people who speak languages other than English, the remote delivery allows us to better connect bilingual and bicultural providers in different parts of a state or region. That is hard to do when you're doing this work in person. In terms of what's working well, there were a lot of benefits identified for participants, providers, and organizations, so across the board. So for participants, they really felt they were now connected to people when they were at a time where they were feeling quite disconnected. They were grateful for services to continue. They also appreciated getting real-time connections to COVID-19 testing information and things that were really changing rapidly, as well as access to food and other services that were harder to get during COVID. Providers really appreciated having a way to keep doing the work they do and keeping the lights on, so to speak, as well as the organizations that do this work. You know, they do this work for a mission, but they do this work as part of their grants or contracts or other services. So being able to do this work remotely allowed providers and organizations to keep doing what they do so well. We also learned some really great tips for doing this work remotely. In general, if you are doing work remotely, you've got to spend more time on the front end supporting people to use remote modalities. So whether that's orienting somebody to Zoom, getting them set up with a loaner tablet, those pieces really made a difference if you spent that time up front and then delivered the program in a class. We also felt like people shared, they felt this was an opportunity to pilot or lay the groundwork for doing these programs post-COVID. So we've had to do this work remotely now, but as the vaccines are spreading and as like the world feels slowly but surely opening up again, many organizations are thinking, how can I keep doing this work remotely? And I've been able to test and experiment over the last year to figure out how to do this well. This includes things like distance training, as well, other ways that we can build capacity without gathering in person. So in terms of what's not working well, similar to the who's not being reached issue, really a lot of the challenges have to do with the technology. Participants may not have the devices to access the technology. They may not be able to afford the broadband, or where they live, it's not offered or available reliably. people may not want to use technology. It's just not something they're comfortable with, or there's a lot of kind of fear about some of the privacy issues. And then they may not know how to use it, and therefore it becomes a barrier to participating in a program. Some of the other challenges we heard were around the additional time it takes for organizations, for these evidence-based programs, for these leaders to do this work remotely, and kind of to both build the remote models and then orient people to technology. And there's a concern about, that may cost more initially, but how can that cost be spread over time? There's also a just building the plane as we fly it kind of challenge, where even though that can be very invigorating and excited, it means folks are really working hard to make this work happen remotely. So what have we learned from this last year and from this survey? We're excited to see that evidence-based programs can be offered in a variety of remote formats to not just meet people, but also the providers and organizations where they are. That these programs are acceptable to both participants and leaders in a variety of modes. We see similar number of participants in these programs using technology like video conferencing, as well as using phone to do programs. So that's been nice to see that kind of both can work for different programs and different people. And it's just been impressive to see how both organizations and participants have really rapidly adapted to this very different way of doing these programs. So we're really excited to be doing a national evaluation now of these remote programs. So that survey work really set the stage for the value of doing a more formal evaluation. So I want to call out our partners that are supporting this work: the Administration on Community Living, the Centers for Disease Control and Prevention, the National Council on Aging, the National Institute on Disability, Independent Living, and Rehabilitation Research, the RRF Foundation for Aging, and Society for Public Health Educators, of which this conference is part of. And really our goal is to evaluate both whether and how these remote evidence-based programs are working. So back to that REA model, not just looking at effectiveness, but also looking at things like implementation and reach. We would love for you to join us. So there's my email there. If you see this presentation and you'd love to be involved, please reach out. And a big thank you to organizations who've already signed on. So I just want to thank you all for all that you're doing to support older communities during these pandemic times and beyond. We really appreciate you taking the time today, and we look forward to the discussion. I'll turn it over to my colleague, Nick, next. Thank you.
All right, good stuff. Thank you very much, Leslie, and thank you, Kate, for letting me present with you today on the topic of arthritis. It's fantastic, and I'm looking forward to working with you in the future as well. Hello, everyone. My name's Dr. Nicholas Bursick, and the title of my part of this session is determining if the self-directed Walk with Ease program is reaching underserved populations. This presentation complements what's discussed in my C2 Picha Kucha presentation. So if you'd like to learn more about this topic, please watch this recording sometime during our conference. It's available to you, and it's pretty good. I like it. I'm a little partial though. Here's an agenda of some of the key items we'll be reviewing today during this session. First, we'll be briefly discussing the benefits of walking for those with OA, and then we'll review the various components of the Walk with Ease program. And finally, we'll describe the recent study we completed on reaching underserved populations. But before we go any further, I'd like to take a minute and take a little micro break. We've been sitting here together for so long, we got to do some stretching. I'm a fitness guy, so I encourage fitness at all times. So first thing we're gonna do, we're gonna reach up overhead really high, just to kind of loosen up our backs, loosen up our spines, and then open our arms with our palms faced to the roof. Really squeezing those shoulder blades together to open up our chest. Go ahead and rotate those shoulder blades a few times. Just nice gentle circles. Go ahead and twist a little bit in your chair, maybe up and down a little bit. See, don't you feel a little bit better? Now that we're warmed up and thinking about physical activity, let's go ahead and continue with our talk. Because there's neither a cure nor effective disease-modifying drug therapy for OA, the management of symptoms is crucial for those living with the disease. I know it might sound strange and kind of counterintuitive, but research has found physical activity is one of the best treatments for OA. Years ago, people were advised to stay off affected joints, but now we know that cartilage needs joint motion to stay healthy. because the motion of exercise both delivers nourishment to the joints and gets rid of waste products. The key point to remember is motion is lotion. Maybe you've heard this before, but it's a very easy thing to remember going forward. The CDC recognizes several evidence-based programs that teach participants how to manage OA through physical activity. And this is what Kate talked about during her session. One of the programs included the Walk with Ease program. I got my book right here. I keep it beside me. Walk with Ease offers practical advice on how to walk safely and comfortably, while also providing lots of strategies to help keep you walking and overcoming challenges that can interfere with an exercise program. Through a partnership with the Arthritis Foundation, the Osteoarthritis Action Alliance, my employers, offers the self-directed format of the 6-week Walk with Ease program at no cost to all individuals who register for the program through our website. If you'd like to try out the program yourself, please visit www.walkwitharthritis.org and complete a brief registration survey to get enrolled. Go ahead and give it a try. We're all on computers today, so especially if you're watching this as a recording, there's no reason why you can't enroll right now. And once registered, you'll receive a free Walk with Ease guidebook in the mail, plus weekly emails that provide information and motivation to help you complete this structured 6-week program. Specific topics discussed in the program are listed on the screen in front of you. In addition, you'll receive access to a secure portal where you can track walking progress, set goals, access tools, and receive a certificate of completion. Please note, I completed the program several months ago, and I still regularly reference this guidebook. It's very good, very complete. I completed the program because as Director of Communications, I'm tasked with promoting our resources, services, and programs like Walk with Ease to the masses. To realize the mission of the OA Action Alliance and engage individuals with osteoarthritis, regardless of their age, gender, or ethnic background, we recently completed a study to determine if online efforts to disseminate the Walk with Ease program are reaching a wide demographic, particularly minority and rural populations. Very similar to what Leslie just got done talking about. The results of our study showed Walk with Ease participants were predominantly urban, white females, around 62 years of age. At first glance, the program appeared to be reaching those who were statistically most likely to have OA in terms of age, gender, and ethnic background. But upon further review, Walk with Ease had low engagement with minority and rural populations. And this study provided evidence that new strategies for online participants need to be developed to reach those with OA who represent underserved populations. Turning research into action, my organization recently submitted a grant to turn Walk with Ease into an app. So we're very excited about this. And if awarded this grant, we believe this app could be a game changer and be used as an alternative delivery model for bringing Walk with Ease to diverse urban and rural communities across the nation. To add to this, we are planning to host focus groups in the near future with both community organizations and Latinas to develop and disseminate new materials for Camino con Gusto, which is the Spanish version of Walk with Ease. And finally, we recently received a grant to create innovative and practical tools such as videos, infographics, and PowerPoints to better engage providers, patients, employers, and their employees, and thus move one step closer to realizing the key goals of the OA Action Alliance. We'll end today's presentation with a thoughtful quote on the screen. Now I'll go ahead and pause for a moment so you can read this. Some of the items we briefly discussed were the benefits of walking for those with OA, and we reviewed the various components of the Walk with Ease program, plus described how we plan to better reach underserved populations. We're always looking for more partners, and if you're interested in learning more about offering Walk with Ease in a community setting, please send me a quick email and I'll connect you with the appropriate person within my organization to learn more. Thank you everyone for your time.
Thank you so much, Nick. That was great. And thank you to everybody else. At this time in our presentation, if you haven't already thought of some questions or have been thinking of ways to engage with our presenters, we want to formally ask you to type in any kind of question that you have from the portion of our program today. To enter a question, all you have to do is type in the chat box, which you'll find at the bottom of your screen, and we'll begin our questions following this presentation here. As a reminder to anybody who is joining us and would like to get continuing education, the recording and evaluation will be made available in 48 hours. To see your CE progress, continuing education, go to My Dashboard to find your sessions that are in progress or to see what has been completed. Once complete, the CE certificates are available for download. Sophe reports CE on a quarterly basis, and the next report will be in July 2021. So with this information in mind, I would just like to say again, thank you so much to our speakers today, Dr. Kate Lorig, Leslie Steinman, and Nick Burisic. We are so glad that you were able to put your 3 different presentations together for something really wonderful. At the very end of this presentation, and you're done with Q&A, we invite you to exit the meeting and to return to the digital conference site agenda to access our next session, which is at 12:30. This is called Partner Playground, and we'll have a collaboration with our communities of practice and visiting the marketplace. Thank you so much.
Hello, everyone. We are so glad that you joined us today for our presentation. I hope that you thought of some questions that you might have for our 3 presenters today, and we welcome your questions. We welcome additional questions in Q&A or chat, whatever is easier for you. Just to kick things off and allow you to get a little bit engaged with us, we want to share a poll. So let me do that first, and then I'll completely open the floor up to our presenters to share any thoughts and feedback that they have. So if you're ready, we're going to open our first poll. Are you currently involved with any of the following arthritis evidence-based programs? And you can check all that apply to you. So we're not seeing anyone who's working with any of these programs, and that's also okay. We'll talk a little bit about that. So I'm going to go ahead and just end that one poll so that we can look a little bit more further. One question that we've received so far, I'll share this to all of our presenters and you can respond accordingly. How do health educators find out if an AAEBI is available in their community?
Can I get some?
Do we have anyone available to talk a little bit about that? Oh, I see that Kate has posted in the chat. I'm just going to go ahead and read what you have, Kate.
Yeah.
Okay.
Well, I can tell folks.
Thank you.
There are a couple of ways that you can do this. The Evidence-Based Leadership Collaborative, which represents many of these programs, has information about the programs on its website. And I put that into the chat. So that's one way of doing it. Another way of doing it is contact your local area agency on aging to find out what's happening in your area. They should know that. A third way is if you know the specific program you want. So for example, if you want the Walk with Ease program, you would go to the Walk with Ease website. So that's another way of doing that. And then a final way of doing that is all of these programs and links are located on the CDC Arthritis branch website. So there are several ways of doing it, none of which are terribly easy. And hopefully one of these days we'll have a whole national locator, but it's not quite there yet. But those are ways that you can find that. And if you need to know something about a specific program, you can always write me and I'll send you in the right direction. There's not that many of you on here, so I can volunteer to do that.
Thanks, Kate. Those are great resources. And I think the other thing I'll call out is that the CDC Arthritis program currently provides grants to state and local health departments around the country, as well as other community-based organizations. So on that website link that's in the chat where you can find out about the different programs, you can also see if there's a grantee near you and connect with them.
Right.
Presenters, I'll let you share any feedback or questions you might have for the group, and we'll also continue to ask other questions. As you're doing so, we have one question in the Q&A box. It says, does Walk with Ease address lack of available walkable areas in rural communities?
I have the book in front of me. I grabbed it and I opened it up, and there are spots in there that they talk about finding locations where you can walk. So yes, it is addressed there, but I grew up in a rural area, and I'm the first person to admit it is hard. There are challenges with it, trying to find it. What I did personally is I would find the local parks. And there's parks anywhere and everywhere, but finding those things, you can always walk perimeters of parks. There's a lot of places, there's sidewalks, even at parks, or even if you live in a more rural area, walking the perimeter of your property, that helps out as well too. I've encouraged many people to do that as well, but it's definitely a challenge.
This is an answer not so much for rural areas, it's more for urban areas. But during the pandemic, because I got really tired of my neighborhood, I decided that I was going to visit as many of the parks, and I do live in a suburban area, and there are probably a dozen or more parks within 10 miles of me. Some are little pocket parks and some are quite large. And I have now visited all of them, and I'm getting to 15 miles. So I'm getting to know all of my local parks and discovered some that I never knew existed before that are actually quite nice.
Absolutely.
Besides, they're not as boring as my neighborhood.
And last night I went to the playground down the street. I took my kids there, and just walking the perimeter of the playground. It doesn't seem like much, but any movement is better than no movement.
We'll go ahead and launch the second poll just to see if that is any information might have stood out to you during our presentation. The question is, which of the following is not a criteria for an evidence-based learning program? And if you're not sure, just submit a question and answer, because we'll just talk about that. So go ahead and select whatever you think it is. Any final votes or just any final guesses? I'll close this in about 5 seconds. I'll give you some time to read through each and think about it. Okay, here are the results. Could I have a presenter just give us a quick overview about the answer that we have here? Everybody voted on implemented with more than racial ethnic population. So okay, so we'll move further. If there's any questions, just go ahead and type them. Presenters is the same thing. New question in the chat box is, will the evaluation you conducted thus far assist in new recommendations for reaching underserved programs, such as rural populations? And if you touch on this, just any final remarks that you could share.
So I can chime in. So yeah, that really is one of our plans for the evaluation. It's really intended to guide policy and practice, particularly thinking about delivering remote programs in rural areas, thinking about some of the challenges with access to technology in terms of reliable internet and broadband, as well as some of the other just comfort challenges with people who aren't familiar with using technology or don't really want to, quite frankly, use technology to participate in a physical activity program or a chronic disease self-management program. So in addition to getting data from participants, we're also gathering data from people who are trained to deliver these programs and the organizations that have had to pivot from doing in-person workshops to remote to really learn about both what are the challenges, but also what are the innovations? How have they come up with ways to successfully engage underserved communities, whether rural or communities of color, communities who speak languages other than English, and some of the other challenges we talked about earlier in the presentation in terms of doing these programs with folks with other limitations in terms of vision and hearing. So it is the plan to learn, but we're still recruiting for the evaluation. So if you are doing the programs that I listed on the slide, please reach out. I'll put my email in the chat as well. But we're really looking to get new to evidence-based programs organizations, folks who've been doing this for years and everything in between, so we can really reflect the diversity of this work.
Yeah. Let me just add kind of from, we're certainly going to learn more from the evaluation, but just from a health education standpoint, as we're developing programs, this has become very obvious to us now that programs need to be delivered in more than one mode. We have traditionally done internet programs, or we have done face-to-face programs, or we've done one-on-one programs, but we've never, or very rarely, tried to develop programs that can be developed the same program in multiple modes, so that you can take a program either using the mail and telephone, or over the internet, or the internet in real time and the internet asynchronously, and in small groups. And different people like or are able to participate in different ways. And we've obviously seen this already, at least with some of the programs that I'm involved with, had always been face-to-face small groups. One of our sites last April said, why don't you do something with a telephone? Because our folks don't have computers. And so we said, oh, okay, we'll put something together. And quite frankly, I did not think that it would have much use. And as Leslie said earlier, the telephone plus mailed materials has had as much use as our Zoom-based classes have had.
Nice.
And so when we're talking about rural areas, that's certainly not going to be a solution for walking in rural areas, but in some ways it isn't a solution for exercise, because all of our programs come with exercise CDs or MP3s that are specifically developed for people with arthritis and for people with pain. And developing those programs is different than the standard exercise program, because while I was looking at Nick earlier and he was raising his hands above his head. Well, I'm a few years older than Nick, and my hands only go this far. And so as we're developing programs, and I knew that he didn't really want me to get my arms above my head. I knew that, but not everybody does. And so you have to really, really work at developing these programs so they're safe for people and that they don't make people feel totally distraught because they can't do what they could do when they were 40. And so this whole idea of multiple modes, multiple ways of doing things. And I really, really resonate with Nick's that any movement is better than no movement. One of the messages we get is the most dangerous exercise you can do is none. And enough said.
Thank you so much, Kate. That's really helpful to hear. And while you're talking about those different modes, we actually have a question that came in, and it says, what has the level of effectiveness been in utilizing phone calls as a method of outreach? This person works as a telephonic health coach, so they feel like these programs will be very applicable.
Absolutely. I mean, if you're already a telephonic coach, if we could get coaches to refer people to programs, or what's even better, the best way, quite frankly, that we found with referrals is that the telephone coaches say, we have these great programs. Would you like somebody to call you? Don't ask them to call, because they have to get down the number and they have to be able to find it, and then they have to call. But would you like somebody to call you? They've now given permission. There's no HIPAA problem. And so then you pass off their number to an organization that's actually giving the programs, who will reach out to them and say, we understand you'd like to take a walk with Ease program. Let me tell you a little bit about it. So absolutely, we would love to get telephone coaches more involved in referrals.
Yeah, thanks, Kate. And I think building on that, depending on your organization, and some coaches can be trained to deliver some of these programs.
Sure.
So the programs really use a variety of professionals and peer leaders depending on the program. So that's one of the things you'll want to think about in terms of which program's best for not just my community that I serve and what they want and need, but also the providers we have. And so in some of these cases, these programs are training up coaches, peer leaders, lay leaders, and others, they require some different professional credentials. But yes, I totally agree. We're trying to really do a better job of engaging folks who are isolated even before the pandemic, but particularly now. And if a coach is connecting to someone, that's an awesome opportunity to get them connected to these programs. I think the other thing I wanted to add on to what Kate said earlier is, all these programs, whether physical activity or self-management, are all really person-centered. So they're about teaching skills to help people come up with things that are meaningful to them that they can do now, and then build on them. So whether you're, limited to your bed, limited to your chair, or able to walk around your neighborhood, it's kind of finding the best fit for you where you are now so that you can live a healthier, happier life.
Yeah. We've talked about the arthritis evidence-based programs today, but I should mention that there are a huge range of evidence-based programs. When I say huge range, there's probably altogether 30 or 40 programs. And we're talking about the ones that are arthritis specific, but there are also programs. Leslie heads a really nice program which deals with depression called Pearls. There's diabetes programs. There's a nice program to help people put together end-of-life documents. So it's really worth looking at these programs because a huge amount of research and effort has gone into not only finding out that they work, that they do something for people, but also that they can be translated into other organizations, including the ones that you all work for.
I'd like to launch another polling question that we have, and it's a little more focused on some of the content that Dr. Nicholas Brasic shared. So the question is, are you personally adhering to the physical activity guidelines? For example, 150 minutes per week. So we'll launch this poll, and then, we can talk a little bit more about what that means. All right, and I'll share the results right here. Nick, let me know if you can see them. We have 60% yes, 40% no.
And that's pretty normal. I've worked with many health educators over the years, many interns at my old job and at my current job. And one of the most common things I hear day in, day out from these health educators is when they talk to their clients, they say, you know what, you should exercise. That's like going up to a client and saying, you know what, you should lose weight. Yeah, that's fine, that's good. But then they'll look at you and they'll say, well, what do you do? Are you currently exercising? Do you practice what you preach? And if there's one thing I can recommend today to take home from this presentation, and really the Sophe conference altogether, is, really strive to practice what you preach, because people, they will notice what you do. They are looking at you to be their role model in health. And exercise is one of those things, one of those components. There's really two things I've came upon that are pretty well solid, confirmed, no ifs, ands, or buts. One is smoking's bad for you. There's not too many people that argue that anymore, that smoking's good for you. And the other one, fitness is good for you. It's not really too many people that argue the alternative to that. So being active is one of those things you can do, whether it's going on the walk, and if you can't walk much, anything's better than nothing. But if you like stretching more, or you like group exercise classes, yoga, Tai Chi, Zumba, if you're into the whole Peloton phase, great. Find something that works for you. Because if you can find something that works for you, you'll be able to better connect with your clients over that relationships.
But for those of you that work one-on-one with people, I strongly advise that before you give advice on how much to exercise and that you should exercise, the first thing you ask them is, what are you doing now? And the example is, very recently, my physician said to me, Kate, I'd really like you to walk 20 minutes a day. And my response to him was, terrific. I'll cut back half of what I'm doing now. Because he made an assumption. He looked at my age, he looked at my body and said, she needs to exercise, without ever considering what I was doing. So I learned that lesson. So if you're talking to people, don't give advice, ask first what they're doing. And you might be surprised sometimes.
We have one more question we'd like to ask everybody, which really brings all the presentations together today. And we hope that we hear more from you in the future, not just today. So the question I'm going to share is, given what you've heard during today's presentations, what additional information do you need to do this work? And it can be however this is incorporated in your work. We'd love to hear more about that too. I'll give some extra time since we have a number of responses. I know you want to read those.
And while folks are answering the poll, I just want to build on what Jordan just said. We are putting together some additional webinars to offer technical assistance to organizations like yours wanting to adopt these programs or adapt them. And so we'd love to know what's going to be most useful to you with the poll, because we want to really be responsive to where folks are at today.
All right, we'll give about 5 more seconds. You can check out these answers, and it could even be something that you think you'd be more interested in as well. That's also okay. So here's the results. I'm sorry if you were still looking through, but again, we'd like to hear more from you. So as you're looking at these results, I did add in the chat if you want to see more of these types of webinars, technical assistance, or you also just want to follow up with the presenters. What you can do with Sophe is email info@sophe.org. All you have to do and type in the subject line is arthritis interest. It can be very simple. And I do also want to point out that our presenters did list their emails today in the chat. So just go ahead and scroll through that before we do close our session. So let me just talk through these results really quick. So we have a high response for the highest, I should say, of examples of successfully expanding program access to rural areas, where to get more information on what is being offered in my geographic area, and training with implementation manuals. We had pretty consistent results across the board, but these are the ones that stood out. If there's any final questions today, we'd love to answer them for you, but this is the main information we wanted to share. And again, this work will continue as far as us providing this type of content to you, but we really like seeing how you were interested today and how that might shape future information. So without any additional comments, I do just want to add that if you are joining us and interested in continuing education or anything like that, that recording and evaluation will be made available within 48 hours. You can see your CE progress by going to my dashboard, and you can find all the sessions you've attended in progress or what's been completed. Once complete, CE certificates can be downloaded, And Sophe reports continuing education on a quarterly basis. And again, as I said before, that next report will be in July 2021. So thank you again for joining us today. We hope to connect more with you in the future, not just today. You can exit the meeting and return to the digital conference site and access our next session, and that'll begin at 12:30. Thank you all so much.
Bye.
So long.